There we go. There we go. All right, I think we're actually live. Welcome to the Pre-Hospital Paradigm Podcast. I'm Scott Wildenheim. I got Caleb Ferroni here with me. I got Dr. Don Spanner with me.
Hi.
And we're missing a we're paceless. He's apparently was working an MVA. He'll be sailing in here in just a few minutes to join us. So, for those of you that don't know why we're hijacking your Facebook, and this time around, hopefully, if we did this correctly, your YouTube stream as well. With this whole Pre-Hospital Paradigm Podcast, every Monday we release a recorded version. Actually, it's one long session divvied up into 3 weeks, and then on this fourth Monday of every month, we hijack your devices for a live, hopefully, question and answer. We'd really like you guys to hop into certainly Facebook, and if we've pushed all the right buttons, we also think we need somebody to try that the YouTube chat should work as well, and hopefully we can get some good questions from the audience. We did get some very decent questions from the audience last time, and got some good participation. But yeah, then we're just kind of start with like a recap of the sessions that we had, right, and then. We'll see where it goes. Now, we're going to do something else extra this time around that we haven't done. This is brand new. To encourage you all to throw some comments in there, we've got the University Hospital's grab. We got the University Hospital's grab bag here.
I don't even have that.
Yeah. So if you throw comments in there, and we use them on air,
and it's stuffed full of money.
It's gold bars.
Wow.
Free healthcare vouchers.
Cool.
Only when you're working. So.
Oh wow. Wow. These are nice.
But yeah, we have a whole grab bag. If we use your comment on air, we'll DM you after the session, and we'll get this sent out to you. We've got so obviously the bag. There's a towel in there. There's a glass breaker. There's what else is in there? There's all kinds of stuff in there.
There's like 4 or 5 gift cards for a couple $100.
I'm pretty sure that's not the case. There's a nice University Hospitals binder in there, and a nice steel travel mug. So let us have it with the comments, and with that, so the operational pharmacology was really the basis of the session that we recorded, Dr. Spanner. And we really spent a lot of time on ketamine,
yes,
because at that time we were really ramping up and really getting settled in how we were QAing and watching over that entire system. We
yes,
had some concerns about letting that get away from us, right, and go unchecked. And we wanted to make sure that there wasn't going to be any situation where we had people, legislative people, trying to take it away from us or do anything like that.
Right.
So it's one of those things that we got to be 100% with.
Totally agree.
Every single time, yeah.
Although the other thing is the QA that's being done where John goes out there and makes sure that all the medical directors are interactive with any ketamine use. So we're even reviewing it for the smaller dosing pain management ketamine. And that being said, I am really thrilled with how people are using ketamine. They're following the protocols. They're watching and monitoring patients. Certainly if we're using it for sedation purposes, for chemical-assisted intubation, or if we're using it for rapid sequence intubation for the squads that are trained in rapid sequence intubation, or if we're using it for psychiatric violence or violent behavioral issues, They're using capnography. They're
Right.
monitoring the patient. The pulse ox is on. They're checking glucoses to make sure these events were not caused by hypoglycemia. And I would say that with the help of all of our medical directors and the Overview Medical QA folks, we are getting some excellent care in the
Excellent
pre-hospital
results too,
venue.
yeah.
Absolutely.
Right. A lot of the fears with what could happen, we just honestly don't see. There's a periodic thing that requires a little bit deeper dive because I'm copied on those, on those as well. But for the most part, it's really, really good patient care.
I do not think we've had a Sentinel event, but I think we've learned from the Sentinel events across the country.
Absolutely.
And we've stayed on top of those types of issues.
So one of the things that came up was in the comments for one of the shorts or one of the pieces we put out was concern about its use in head injury, in TBI
Okay.
or situations like that. And early on, we had the protocol a little more constrictive. It was a little tighter than it is now. And as we've learned things over the past, I think it's been in the box, about 5 years at this point, at
Right.
least 4, right? So over the last 4 or 5 years, we've continually loosened that up. You come in because it's a new agent, right? And we're a little overcautious. And the two things that we've really backed off on that were originally written was history of hypertension and the head injured patient.
Right.
So can you speak to the head injured patient and why there's no notation in there about its disuse?
Through animal studies, they've found that that's truly not the case. But since we're not animals, the military's done a phenomenal job on this and found that ketamine, especially in our traumatic injuries
Right.
and many of our military injuries on the battlefield also are involved with head injuries,
Right.
that has not been the case. And it is considerably safe to use ketamine for traumatic sedation in battle traumas. But that being said, it also has an incredible effect that we don't talk enough about, and that is our traumatic injuries, whether they be head or any trauma injury, comes with some PTSD.
Yeah.
And the military has shown a 50% reduction in post-traumatic stress disorders when ketamine is used as the primary sedation agent. So I actually just used ketamine to intubate on Friday a 34-year-old asthmatic. And I can't even tell you the last time I intubated an asthmatic. I mean, we have so much treatment. Our medics are out there starting magnesium intravenously on the bad cases.
Right.
They're hitting duoneb after duoneb after duoneb.
Steroids.
They have the ability to use intermuscular epinephrine, although not my favorite. If they're not moving the meds, they have that. Solumedrol has been changed this year in the protocol to not only be intravenous, but also intermuscularly.
Correct.
There's no reason to not aggressively care for someone, but this poor lady walked into the ER, so she didn't have all the benefits of fantastic pre-hospital care.
Right.
You guys make such a difference before they get to us. I cannot tell you the last time I intubated an asthmatic.
Right.
I don't know. But she's 34 years old. What better induction agent, the sedative before you paralyze, than ketamine? That's going to bronchodilate them. And I know that there's these warnings.
Secretions.
Secretions.
Hypertensive.
Right, and hypertension, and even bronchospasm. And even they talk about cord spasm. But you push this drug slowly, and you're just not going to see that, and you can prepare for suctioning. But I do know that using ketamine in the setting of respiratory failure and asthma is also a bronchodilator. So I decided that was going to be my drug of choice this weekend. We successfully intubated her. Now, she had terrible asthma and was on a ventilator for 36 hours, closer to 48. But she's off. She's on the floor.
Fantastic.
She's alive because we picked a very good induction agent that also assisted in her ventilation. So not only is it no longer contraindicated in head injury, no longer contraindicated in a hypertensive patient, but when we're talking about trauma patients where we're worried about their labile, blood pressure, and possibly hypotensive events. And God help us, we don't want a head injured patient to have more than 2 minutes of hypotension. And when we used to use Versed for this, we always saw hypotension because the doses of Versed required for induction are going to show you a drop in the blood pressure. And that's unacceptable in the head injured patient. Hypoxia, unacceptable in the head injured patient. So we're not only going to get them intubated, we're going to decrease PTSD by 50%. We're going to maintain their blood pressure, which is what our goal is, and we're going to have them more rapidly intubated with an agent like ketamine.
Have you given this talk before?
No.
No, it's the first time.
You asked me to come in here and talk about it.
So funny
Am
story.
I talking too much, guys?
No, absolutely not. It's just that was very polished. That was spot on. So
I'm a yacker.
So just today, released for University Hospitals Geauga, was the RSI protocol for the departments who have been trained.
Yes.
So today marks the start of ketamine and rocuronium.
Yes.
So I thought that was kind of cool that today sums up our ketamine lectures with that as the grand opening.
Yes.
So,
yeah, we spent a lot of time talking about RSI on the recorded podcast.
yeah.
So
Yeah,
it's
pretty cool.
Yeah, it hit the road today, and that's just for departments that are participating and trained
Yes.
for RSI. But we've got that whole new agent switch. We spoke a lot about the reasons why why we made that pivot. So we got a question up there. What are the most common side effects of ketamine?
Well, we do see a raise in the blood pressure. Are we talking about hypertensive emergencies?
Crisis, yeah.
Absolutely not. But we do see a raise in the blood pressure, which is pretty consistent. You will not see drops when you're using ketamine, drops in blood pressure when you're using ketamine as your induction agent, which in trauma, probably a good idea. In severe head injury, not great. But it's transient. The other thing that we talk a lot about, and this is a really good question, the other thing we talk a lot about is emergence. And I have witnessed emergence, but that was 20-some years ago. What I've found is that when I have somebody who's been ketamized for induction, and it's easy for me because I'm in the emergency department, is that I start my Diprivan right away, or I start my second agent to keep them sedated. And I usually do really well and maintain their vitals exactly where I want them. However, in the field, here you have our protocol, which talks about ketamine as your induction, rocuronium as your medium-range paralytic. And then in 15 minutes, if they were to emerge and the paralytic wears off, they could actually, if it was a psychiatric example, they could actually come out of that more agitated. And that's what we mean by emergence. One of the things that blunts that very well is the benzodiazepine class. So you're not going to see somebody get hypotensive if your benzo is Versed with 2.5 milligrams of Versed. But what you're going to blunt for the side effect question that was asked is the emergence. If you have Ativan, 1 to 2 milligrams of Ativan IV is not going to drop anyone's blood pressure, and you're going to blunt the emergent complication. The other thing that we worry about, of course, is the bronchospasm, which if you push fast could be a risk. I've never seen that. My daughter has actually seen that. Yes. Cord spasm. And this is somebody who gets slam bolus ketamine, and no drug needs to be. There's only one drug in your box.
Adenosine.
Is
Correct.
that's
There's only one that gets a running start.
Caleb, Caleb, can you think of any other one that needs to be pushed like a jackhammer? No.
Absolutely not.
Tetracaine in the eye?
No, one drop, maybe two.
But it's bolused.
So I hope that answers the questions on side effects, because those are truly the big ones that I'd worry about.
And like every single medication, maybe you're making a great point here, is that rate of administration is what gets us into most of our side effect problems, right?
Absolutely.
We have to take some ownership on the fact, that
Dilaudid.
we are controlled.
Just think about slamming Dilaudid in somebody.
Well, I mean, the rigid chest of fentanyl, right?
The rigid chest of fentanyl is a fantastic
You get a
example,
running
Scott.
start, well,
I mean,
you can cause problems.
I have never seen that, but I've heard people that have. I don't know, John, have you ever seen that? I don't know if he's listening.
He doesn't have his headphones on. I
Okay,
guess
so,
not.
so I will tell you.
Laryngospasm?
Have you ever seen chest wall rigidity from fentanyl?
There he is. All right.
Hey, come on in.
Late to the.
Sorry.
Hey, you were taking care of patients.
John, have you ever seen that?
Never seen rigidity with fentanyl.
No, but I've had people talk to me like they have seen it, and I would imagine it's due to somebody just jamming it in.
Yeah.
But I've given thousands of
Right.
doses, and I've never seen that. And what do you have to do? You have to have a paralytic on board. So do you think we would put a drug out there that actually has that event? And we have it in 250 departments, and we've never experienced that because everybody knows you push that drug
slowly.
gently. Yeah.
Yeah.
It's a good point.
It's all right. We got another question up here. Would it be a good idea to give ketamine for combative trauma patient with possible head bleeding, even if our department can't RSI? I think we kind of answered that for the most part, and it's
I think
you have to.
absolutely.
You have to, yeah.
I mean, if your Glasgow is less than 8, that patient needs to be intubated. Because if you let your head injured patient, who may even have a brain bleed, of course, aspirate, your mortality is going up by 50%. So what are we weighing here? We're weighing the benefit versus the risk. And here the benefit of getting a protected airway on a critically ill patient. And again, you got to look where your trajectory is. Okay, let's take a look.
Your clinical
If
course,
I'm
yeah.
5 minutes away from a trauma center, and you go where I work at Ahuja, which is not a trauma center, but I've got my A scope, I've got my glide scope, I've got multiple respiratory therapists, I got people dabbing my forehead. I mean, it's a whole lot easier.
I've been to a Hoosier. I know that's not the
Right.
case.
It's a
Thought
whole
you
lot.
stopped working for him.
It's a whole lot easier for me to take a difficult airway and control it than it is for you. But if your trajectory is out, and many of our departments are 30, 40, even an hour away from a trauma center, and you're making a mad dash to a trauma center, you've got to protect that airway. And if you're not an RSI department, ketamine is a phenomenal way to disassociate somebody, and you've got a beautiful range. It's 1 to 2 milligrams per kilogram. Never give less than 100 milligrams to an adult trauma patient. Our protocol is 16 and over. And if you start with 100 milligrams in your average size person, because I don't do a lot of math during an emergency. I mean, everybody that knows me knows, don't ask me to add anything up, okay? I look at you, your average size, you get 100 milligrams. Your big size, you get 150, okay? You're going to disassociate the patient because that range is anywhere from a 50-kilo person all the way up to a 150-kilo person. So you have that covers everything, those 2 doses for the most part. And that person will disassociate safely, and you'll prevent aspiration. And I think that's a critical point, way more than the actual blood pressure for a brain bleed.
Correct.
If that answers the question.
So the other point we need to, we've gone in the podcast proper, plus here, of course, all of the benefits of ketamine, and we know it's an agent we want in the box.
Yes.
But now that you're here,
Yeah.
we need to talk about reality, and that sometimes things go on shortage, and there's a threatened shortage on
Yes.
ketamine right now. So the good news is that all of those protocols that ketamine's indicated in has some backup plans, right? Now, of course, we would prefer you, if the ketamine's available, to use that for all the aforementioned reasons. But let's run through those. If we have to take, well, first of all, what are you hearing from the pharmacy side of things, and out of that camp? I heard some shortages maybe at Parma, or I was copied in some emails on that. But there seemed to be a bank of it on the east side.
Yes, we started with a ketamine shortage on the east side, mainly Geauga area. We were able to navigate that. Fortunately, we're really lucky. We purchased drugs from multiple vendors. We were able to access a different vendor that had it in stock, so we were able to purchase enough to keep Geauga. And the big thing is whenever there is a shortage, we want to navigate that shortage with, obviously we want to try to replace it with the same drug, but we really like to stick to the same concentration, right? Because if you if you change the concentration of the drug, I think that's more dangerous. It's just, we always have that false sense of
Muscle
security.
memory.
We grab the ketamine and I'm thinking this is 505, so I have 100 per ml, and maybe you have 102, and then
Right.
it's dangerous when you change concentration. So UH Pharmacy does a great job navigating shortages. The nice part about our system too, when there's a shortage, we can actually share drugs amongst the system. So if Jogger or Portage has
Do some load balancing.
yeah, 100%. We could share, and that makes it that's very beneficial. So we just dealt with ketamine shortage at Parma. We're working on navigating that, whether we share from another hospital or we get it from another vendor. The hot topic for a shortage right now is for Versed. Versed, Ativan. We just had I want to say
There's
it's
a
Acorn.
shortage coming on for Versed.
Yes.
We already have an Ativan shortage. So.
Yes, and then with I want to say it was
One may have
Acorn.
caused the other.
Yeah, yeah.
Yeah.
I want to say it was Acorn, pharmaceuticals had just closed.
Yeah, yeah.
So that's placating into it. Shortage wise, we're navigating Versed right now, and possibly albuterol.
Correct.
As well. I know everybody's checked their emails lately. The state of Ohio just pushed that email out. But no, pharmacy does a great job. We really try to replace the same drug, same concentration as best we can.
And furthermore, they do an amazing job at prioritizing meds they do have for EMS. And
Yes.
if you lose it, if you don't have it in the box, it's not like they didn't try real hard. I mean, to get it out to us. Right.
Correct.
But that does bring up. Let's go to the. If you have to take an airway and we're short the ketamine.
Yes.
Right. So this year we made a protocol change, and it was in the rollout, but it was
Anticipated
like
loss?
it was just boop. No, that was last year. It was just boop. It was just this little blip in there, because historically, if you didn't have ketamine, which was the more optimal choice, the only other option was just to do Versed only. And what was missing there, because it's a good sedative, a good hypnotic, but
Yes.
it does nothing for pain, right? It has
Nothing.
absolutely
That's a
no
critical point.
correct. And we added this last year. If you find yourself and you got to take an airway, is you can add the analgesic, you can add the fentanyl right on that page. And
Yes.
somebody that was in the know could have played the game and be like, oh, I tried to intubate my patient and they were in pain, so I gave them some you could have pulled multiple protocols together, but you had to know to do that. And that's not right. We made a pivot on that. We've changed and we've added that.
I mean, that's just the perfect segue, Scott, and that is what a fantastic drug for induction and analgesia.
Right.
So here you have a drug that you can disassociate somebody, and we all know that trauma comes with pain, and you can control their pain. I mean, that's phenomenal. There's a question up there that's actually pretty interesting.
All right, it's all you.
There's a hesitancy in using ketamine on patients that are hallucinating and combative, or even MR or autistic people. Is it okay to use with them? And that there is some evidence. Now, this is remote in schizophrenia, that adding ketamine could exacerbate their mental illness. And certainly we don't want to do that. But those are also the patients who can become dangerous and violent. And certainly want to do everything we can before we ketamize somebody intramuscularly, 250 milligrams, and you can repeat that dose a second time, in somebody that's a danger to themselves or others. And I'm talking extreme danger. But just because they may have one of these diagnoses listed in the question doesn't mean that the situation has to be controlled. So these are the patients that you may in fact have to utilize ketamine for to protect yourself or others. Much better than holding them down and laying on them or affecting their airway or their breathing, and now you're actually hurting somebody. In this situation, you're controlling a situation, realizing that you may exacerbate some issues. Let's get the benzodiazepam on right after the ketamine. So what I do is ask the squads or myself in the emergency department to ketamize the situation, put the soft restraints on, and after 5 minutes of setting the stage with the capnography and the pulse ox and the monitor, adding an additional drug, which is your benzodiazepine. And that should blunt the exacerbation issues that you'll see with autism and schizophrenia.
So if we know that this is a, did you have something?
I do.
Go ahead,
So
go ahead.
a lot of good feedback has been throughout the last sessions of ketamine. I've heard more so about ketamine than I have CPAP or anything else we've done.
Awesome.
Which is great. But I wanted to read back something that you said during one of those podcasts that people really liked, and it was all people sense empathy. And that when you show someone that you care, you become a trusting enough to help people help themselves with your plan. And I wanted to read that back to you because that hits deep. And just the other day, I was texting you about something that one of your other family members did.
Yes.
That approach to care is what we're lacking sometimes. And I think it's important that we remember we're patient advocates first.
We're not just patient advocates, we're also human beings, and we're all in this together. The patient's part of our team, we're part of their team, and spiritually, we owe something to our patients.
So that case, right, that you just brought up, right? So we have this known schizophrenic. It's an exacerbation of that, but they are violent and they're going to hurt us. We give them the major tranquilizer. We take control of the situation. Going back to helping their underlying illness, is that also the patient we should be on the phone with med control once we do those protocolized things? Say, should I consider giving them the haloperidol as well? Should I give them the Haldol?
Okay, so fantastic.
With these things to treat to actually treat the underlying condition.
I have to tell you, I just actually had Macedonia, and it's okay to
Of course.
name the department. So I just got called to the radio. I want to say Friday night, and I had Macedonia Fire call me with an incredibly violent situation, and yet they recognized that they already had handcuffs on the patient. Right? And the patient was smacking their head against the side of the wall of the ambulance.
Truck,
So they put a pillow there. So now they're controlling the head injury. They have the patient restrained, so there's no way anyone's getting hurt. And they wanted to ketamize the patient. And they said he's a schizophrenic. He's off his meds. And I hope this, thank you for bringing that up. I hope this answers the question even better. They called med control. And they thought enough and said, Doc,
There's more to this.
there's more to this. They go, the guy's restrained. We got a pillow here. He's losing it. I said, so let's treat the illness. Let's treat the illness. And I think your question was more like, if they ketamize him, can you add the Haldol? I would add the benzo first, and as they come out, see what's happening. But what I did is, because the situation was still violent, but not dangerous.
Correct.
I think danger has to be part of the situation to actually knock somebody down with ketamine for behavioral issues.
And I think you even alluded to the fact that if you think that you need to use a taser, that's the time to use ketamine.
Absolutely. It's your chemical taser. So what I did is I said, give them 5 of Haldol. They didn't have Ativan, so I said, give them 5 of Versed. IM Versed is really rapid. And give them 50 of Benadryl. IM. That patient came in and laid down in room 11. 6 hours later, he was eating and having a grand old time. He just needed to be back on his meds. So what did we do? We successfully treated his medical illness.
Isn't that why we're here?
Yeah. Exactly. Thank you, Caleb.
Now
That's
you brought up
exactly
another
why
point,
we're
though,
here.
that I wanted to hit on. We talked about it before, but it's been asked again. You're giving the B52. What can you put in the same tube?
Okay, so good question. Ketamine should be in its own syringe. I mean, I just think that's the better way to do that. I just haven't read enough about it, So like when we used to do, remember when we did Sucks and ketamine? What was it?
Etomidate.
Sucks and etomidate, and we did Sucks and ketamine and that type of thing, and we would mix Sucks and ketamine. Yep. So ketamine was 1 cc, which was 100 milligrams, and Sucks was 5 cc's, which was 100 milligrams, all in the same syringe, intravenously. Everybody's happy. It was easy.
Right.
But I don't know about mixing ketamine with rocuronium. And so if I don't know on a podcast or even in my medical care, I just don't feel comfortable just telling people to do that. So I have them separate.
The next time you come on, you can let us know if you've done it.
Okay.
Get your clinical your clinical pharmacist involved, and we'll go from there. But
And analgesia, I mean, these are great. Like you said, ketamine's great for that. And I love what you said before. And so I've been pushing it. Waste 1, pull 1, waste 7, and that leaves you with the 3 that you can give. And I think that's awesome.
If we have no changes in the concentration, right?
Yeah,
Correct.
right, yeah.
So that push 1, pull 1, and give 1, and then waste the 3 so you don't overdo it. That works with the 500 milligrams in 5 cc's. It's a little dicey when all of a sudden you have 200 milligrams in 5 cc's.
And the
Don't even ask me that math, please.
Let's hear it.
and I think the 3 big take-home points, the 3 heavy-hitting points for when should we use the low-dose ketamine or the 10 milligrams per milliliter, and of course that push 1, pull 1. That really we really hammered down on 3 patients, right? The one that is working an opiate program, right?
Absolutely.
Because you have a non-narcotic, right, that has the lifting power of our narcotics.
It doesn't even,
But it doesn't mess up their recovery. Patients that are well acclimated to narcotics, right? So if all their mu receptors are flooded,
right.
sneak around the edge, and we can try the ketamine, or people that maybe are active, say heroin users,
right.
And you can give them all the Dilaudid in your box, and they're going to still look at you cross-eyed with their broken femur fracture, right? So try a different attack vector there, and then you touched on it a little bit ago, which was shock trauma patients, right?
Yes.
Being PCP and a stimulant, we would expect it to actually augment and help blood pressure and a little bit rather than.
So backing up to the analgesic patient, I would tell you that one of the things that has been most satisfying is with sickle cell patients who have profound chronic pain. Because if you think about it, why does a sickle cell patient have pain? They have pain because they're not oxygenating the bone because of the sickle cell, and it's like micro fractures of the osteocytes.
That just sounds.
Can you imagine if you've ever broken a bone, how painful that is?
Yeah.
Imagine breaking your bone every minute of your life, because that's what a sickle cell patient feels. And so they have my utmost empathy. And yet, they're on massive doses of Dilaudid. Some of these people are taking 4 milligrams of Dilaudid every couple hours. And when they come in the ER with pain, they're in pain. And these are the folks that a lot of people have short fuses with. Oh, it's a sickler. I find that abhorrent, because that person is really in profound pain, and they've overused narcotics so long that they have no effect on them. That's not a drug seeker. That's a sad situation.
Very sad.
And nothing is more satisfying than using ketamine, a completely different agent. Now, there are some mu effects with ketamine that people don't talk a lot about, but for the most part, it's a different receptor.
An MDA, yeah.
An MDA, and also GABA somewhat. But both of those receptors being attacked, one antagonized and one, actually assisting, is actually going to give them analgesia from a different angle, just like what Scott was alluding to. And all of a sudden you get these folks who have pain relief, and you should see their faces. So it's not just for the one that you don't want to get rehooked on narcotics, so you need a different avenue, because we have Toradol for them too. This is for somebody with significant pain who needs more than an NSAID, and the narcotics don't work anymore. Think about that ketamine.
Yeah, and you're exactly right about the sickle cell too. If you have a sickle cell patient who says they're in pain, they're in pain. And you need to trust that.
Yes.
And not be biased over your opinions on that. You need to treat that patient.
Absolutely. Hey, this looks like a good question.
Yep, hit that.
At what dose would you expect to knock out a patient's respiratory
We
drive?
don't need to be here, he said.
Is it
We're just going to get him walking out. You got this. We're just going to call this a Don Spanner hour.
is it
And also, Matthew, you only get one handout per all your
we're not,
questions.
we're not sending you two.
also John is an ER doc right behind running this show, and I just got to tell you something funny. We're very ADHD, so while I'm trying to always focus, but my eye rolls, and there's another question. So, at what dose would you expect to knock out a patient's respiratory drive? Is it anywhere close to the dose in the protocol? So, I got a great answer for this because it's a great question.
Right.
And Scott knows this because he and I actually were bonding during our first presentation of using ketamine in the university system about 8.5 years ago. And what protocol were we looking at? We were looking at Columbus. Yep. And Columbus was not using it for intubation. They weren't using it for pain because that hadn't all developed yet. They were using it for their psych patients.
Violent. Yep.
And the violent psych dose is 3 to 4 milligrams per kilogram. So they were starting at 500 milligrams. And even with a 500 milligram whack intermuscular dose, Columbus had almost no issues. But their literature, which was very well published, I mean, Dave, who was their medical director for 25 years, was just one of these phenomenal people who really was the tip of the spear in a lot of this pre-hospital care. And he actually reported 4 apneic events at 500 milligrams
Out
of hundreds.
Right.
And so, to answer the question, if you do double the dose of the protocol start, you could see an apneic event rarely. I hope that answers the question. 250 milligrams given 5 minutes,
5 minutes apart.
per
That was
the
good
protocol.
spacing, yep.
Now, we started at 2, and we had 1 apneic event. And I'm not going to mention the department because they did a great job. The patient absolutely needed a second dose. And they had, managed their airway very well. So I can't really call that a problem, but that particular event made us move it to 5 minutes because of how long the onset actually is for ketamine. And guys, correct me if I'm wrong. If you do 250 and repeat it in 5 minutes if needed, IM again, both IM doses. We haven't had an apneic event, have we? In the protocol?
I have not seen one in the biweekly reviews.
So it truly is a very safe dose, and our protocol should not have this event.
And yet very effective.
That
So it's
that half dose, that 5 minute spacing
Helps a
were
lot.
key. And if I can add one more thing from my recall of when we were looking at Columbus's data, those apneic events they did have, I think they were all intoxicated, if I remember, with alcohol, or mostly.
I think you're absolutely
3
correct.
out of the 4, there was some propensity for that needed to be our take home point. There is caution.
already had
Caution.
some sort of respiratory
Correct.
depression.
Correct.
So alcoholics can get violent, is that what you're saying?
I've never seen such a thing. They're always super cooperative.
I'm nervous. I'm getting nervous. Yeah.
Oh, you want to talk about something else? You want
Lead the way, guys.
You want to transition a little bit? So, since we recorded that,
Yes.
I don't know if you saw this, but I had to make a little lead in to our episode because we recorded that and then we promptly went behind closed doors and changed the protocol and everything we talked about. Well, I say everything.
But to be fair, how long ago did we record
Several.
that?
Yeah, it was in the middle of last year. We tweaked some stuff, and we tweaked 2 things that we talked about in one avenue, and that I just want to make sure everybody's clear on. Is the dose of TXA and the dose of and the changes we made to push dose epinephrine, right?
Okay. So I guess I'll start off with the real easy one. We didn't really change the dose of TXA. We just changed breaking it up.
When and where it was given.
Right. It's the same dose.
Okay.
You know, the dose of TXA is 2 grams. And I need to look here.
No. I'm just saying the world might not know that there was follow-on in the ED. There was a
Yes.
follow-on before the patient went to the OR
Right.
with another gram.
Right,
Right.
which was frequently missed.
Yeah, I think a lot of squads didn't understand that, or didn't maybe they didn't see it. To
Yes.
your point,
Sure,
yeah,
sure.
maybe they didn't see that dose. Like I gave my gram in the field, I take him in, we start doing the trauma assessment with the physician or the trauma surgeon there, and then your handoff was complete. So I don't think we really saw that hospital dose of TXA.
Right.
Yeah.
And so why mess with it? Well, believe it or not, we did not lead this. Because we're so used to the institute being, bringing up things and making things happen. This actually happened through Knott's and through a physician. I think they were from Akron General. I can't remember which physician brought that up, but it was really very good. And so we presented it to Knott's, and we had the Knott's leadership come up and basically say, why don't we just give this drug the way they're doing it nationally now, which is the pre-hospital folks, instead of taking the 1 gram, putting in your 100 cc bag at basically, almost wide open, because you got to get 100 cc's plus the vial in over 10 minutes. Just add 2 vials to that 100 cc bag, or you can inject it slowly over 10 minutes. So there's 2 ways to do it in the protocol. One is a straight bolus over 10 minutes, and the other is through a drip. And it doesn't really matter how you do it. The problems you're going to see with TXA by giving it too fast could possibly be hypotension. And no matter how you give it, there is a small risk of anaphylaxis. And so what would you do? You treat it the way you treat anaphylaxis.
Epibenadryl steroids.
Yeah.
What?
And epi. So what was the other drug we talked about? Oh,
So yeah, the push dose epi. But the point, just I'd like to reemphasize that just to make sure that everybody's crystal clear on that is, if you're going to hand push it, you still have to hand push it over 10 minutes.
Yes.
right?
Correct.
Yeah,
Yes.
that's.
If I wasn't clear on that, absolutely.
I just wanted to make that stated because everybody's like, "Oh, it's in a syringe," and I mean, you put a syringe in most providers' hands, and it's
So I still
we want to just give it all immediately.
So I still hang the bag. And why do I hang the bag? Because there's no way
Correct.
I have the patience of pushing a syringe over 10 minutes. It's never going to happen.
Well, we just don't have the people.
Right.
No, and that's the nice part about being able to inject it into the 100 ml bag at D5, put it in there. You could set a drip rate, and then I could keep working on the patient. Maybe I'm doing a secondary exam now, but I'm moving on to something else. So I do like that. And it's controlled.
Most often when we're pushing this is because they're bleeding, so we're probably starting a second line and trying to patch holes
Plug
as
in
well.
holes, yeah.
Something cool that's coming down the lines, I'm probably not supposed to say this yet, but somebody named Don Zimmerman is working on a bleeding mannequin. And
No kidding.
It'll be really cool. One thing we worked out was putting the appropriate amount of fluid in the mannequin that you'll almost be able to visualize as you're losing it to see, I've got to patch holes, I've got to stop this and do everything else, and this is how much time I have. It's going to be phenomenal when he's done. I think he sent us a video the one day of him working on it. It's pretty good.
Doing some.
He's out of town tonight. That's why I want to pick on him.
Well, he actually helped out with our Ashland protocol procedure day, and he was kind of talking about that, alluding to it.
I'm excited.
Well, whatever he does, it's always a bunch of fun.
Correct. Correct.
Like what he did with the Lucas, I think has completely changed how squads apply the Lucas. And what he did with OB and our
And
OB
his-
mannequin has made people so much more comfortable, because hospitals are, bringing their assets, and they're like, this hospital is going to be interventional. This hospital is going to be our OB. This hospital is going to be a trauma center.
They have to specialize.
We just can't. There's no longer this idea of a generalized hospital and all hospitals can do everything. It just can't be done. So that means that we're counting more on pre-hospital providers to get our patients
To the right
stabilized to the right place at the right time for the right care.
Yep, and he'll be bringing that around in the sim truck, just like he did with the OB mannequin, the OB mom, and
So not to make him busy, but sign up now.
I think that's good.
Sorry, Donnie.
start bugging him now.
Do you guys see another question?
So we do have another question up there, or another ketamine question. We can go back. This
Sure.
is yeah. So Any street drugs that we should be concerned about that may alter the desired effect of ketamine? There's a camera in my way. I think I'm paraphrasing, but I think that's what the question is.
Okay. I think my answer would be under the situation, because we know that ketamine is chemically related to a street drug called Special K, which interestingly is ketamine, but also has the effects of PCP.
PCP, right.
And so would you be adding to that? And the answer is actually no, because that's what they talk about when they talk about street drugs that would affect ketamine because of its similarity. What we're looking for is to pass through the recreational level of ketamine and move into the disassociation level of ketamine. So you're actually just taking their high that has become violent and moving it from high to disassociation. So that should be very safe. Other than that, I can't think of any street drug. Certainly the stimulants are concerning. The amphetamines, the
coke,
cocaine, the meth, those types of abuse agents certainly are already hypertensive, they're already tachycardic, and so we're going to raise their blood pressure a little. But they, in a dangerous situation, we can control that after we control the patient.
If I can be oversimplify that, if you know that their blood pressure is high and you're worrying about it, it's already not the correct agent because they were fine enough for you to get a blood pressure on them.
That's a really good point.
You should be
No, I love
using
that.
Versed, right? If you know that their blood pressure is too high, then they've already let you do things to them. It's not the
Yeah, I was
not
just
the right
saying
track.
that physiologically they're
Correct.
going to be high.
Correct.
I wasn't saying you were actually going to get a blood pressure on them. Good luck.
Oh.
Hey, I know you're trying to beat me up, but could you hold your arm
Why
still?
don't you hold real still? And I need to check your glucose.
Okay.
But
What about Narcan? You guys want to talk about Narcan for a second?
I don't. But
I ran something by you the other
No,
day, and
this
I'm
is a
curious.
really good one.
He-
Caleb,
he
this is
loves talking
important.
about this. So
This is
Is
important.
Narcan going to work for this?
Is Narcan going to work for...
Ketamine when I overdose my patient.
ketamine,
Oh, right. So we didn't know that.
Ketamine or
but that's not
PCP?
exactly where my question was going.
Okay.
I had a OB class the other day,
Yes.
and Don Zimmerman helped with it.
No kidding.
And during the class, we had talked about there was a case. I won't mention names, but it was very interesting. Mom was an opiate user.
Is this the baby born in
yes.
the toilet?
I don't know about that.
Yeah.
Mom was a user. They ended up ultimately needing Narcan on the baby.
What hospital did they go to with the baby? I want to say St. John's.
West Shore.
Yeah, that sounds right.
Okay, I know the case you're talking about.
So-
I reviewed that case.
So
Yeah.
the question for the class was they ended up giving Narcan to the baby, and the baby did restore respirations, but was it warranted? Because there was a little like, good job, it's in the protocol, but next time maybe just bag if you could.
Okay. So I actually was notified by the neonatologist that the child was in withdrawal. Certainly Narcan, increases withdrawal quickly.
Sure.
And they would have preferred that the child just be bagged to the hospital because they actually were going to do this anyway, but the child was on a morphine drip because of the withdrawals, secondary to coming out of mom and no longer having narcotics in their bloodstream. It's actually a pretty tragic case. It's very hard to give a squad any grief when they're saving a baby's life. And so this was a very soft, teaching point as far as I was concerned. The Narcan absolutely put the kid into withdrawal faster, probably increased the risk to the baby, but they could have managed this baby just through ventilation. And why don't we then move away just from that particular call? And I hate, if you want me to go back, tell me. But let's just talk about Narcan in general, okay? If you're sitting there with a narcotic overdose patient, and we know that the reason a patient with a narcotic overdose is unconscious because of respiratory depression. So you decrease their respiratory drive. What happens? Their CO2 starts to climb. It's the CO2 narcoses that puts them into this unconscious state. So how do you guys treat CO2 narcoses? You bag them. Everybody's going like this. Yeah, you bag them. And you get their CO2 back into the normal range. And son of a gun, they're going to actually wake up on you. The reason we use Narcan is nobody wants to bag somebody for 4 hours or even 20 minutes with fentanyl, right? I mean, that's literally, you don't need Narcan to save somebody's life from a narcotic overdose. And there was a period of time, and I was never keen on this, where ER doctors would talk to each other about who gave the most Narcan, okay? And I actually have a really good friend who's got 26 milligrams in a patient, and he thinks he should get a badge for it, okay? And I was like, and I know you guys know him, and I was like, dude. So I'm just going to call him Dude, okay? I was like, dude, really?
Dr. Dude.
That's what you're thrilled about, that you hit 26 milligrams?
Right.
And he goes, yeah, well, you know, fentanyl and certainly carfentanil is so powerful. You got to really hit them. And I'm like, just bag them. Okay, give them the Narcan so you don't have to ventilate them. But the whole thing about Narcan, and now we have the police, and God bless the police when they're out there trying to help folks, and they're shoving Narcan in people's noses. And how many times have you guys, just think about it yourselves, have gone to a narcotic overdose who's gotten 4 doses up their nose? Right. By the way, did they wake up?
Nope.
No, they're not awake until you guys give it IV or IM.
Right.
Because
IM bag them for a while.
Oh, you bag them a while.
For a while, right? Yeah.
And hopefully the only reason
100%.
we're giving it is to restore respirations anyways. We don't want to wake them up.
Exactly.
Correct, because then if not, then we get the violent because we've immediately
Throwing
taken
up.
them.
And then what are we going to do?
Tachycardic hypertension.
And
Yep.
those are ketamine to knock them back out.
Yeah. We create a bigger problem that way.
You
So
know-
it's easier just to support them.
You know, when they teach, because all the departments teach the police their CPR each year. While we were teaching them CPR, we would be better served to teach them how to use an ambu bag
True.
than to just teach them to pour gallons of Narcan down somebody's nose to ensure that we drown them in Narcan. Right. I mean, Narcan intranasally takes 8 to 15 minutes to work.
It's a long time.
Let alone
It's
the
too long
barriers
a
with
time.
it. Let alone the barriers with it. They're not breathing. They have all the mucous membranes are plugged, and now
Right.
we're giving them something to be atomized, but they're not breathing enough. We just need to support the respiratory drive.
Absolutely.
So another question came up with the Narcan and the police, and I'm glad you said that. What do we do in a suspected opiate overdose on a canine who's assisting a cop? Now, believe it or not, that's a true question. Are we permitted, because they are canine officers, to administer Narcan to a canine?
So let me clear something up right now, okay? Because you're going to get a lot of hate mail for this one, okay?
Probably.
Okay.
It's Charles.Ferroni.
By the way, my name is John Hill. So there's a reason they call them drug dogs. Okay, they got snouts that are a foot long.
Right.
Okay, there's no fricking canine that is snorting up the heroin and passing out from it. Okay, folks, this is like folklore. That doesn't happen. Okay, doesn't happen. Could they give a dog Narcan? I guess, but it's like crazy time. I mean, it's literally crazy time. It's like when you hear people say, we were in a room and there was all this heroin and I got high. Yeah, no.
By association.
By association, you know.
No, I heard that the other day and I was like, I never thought about that. And
Yeah.
so just the other day I was on an MVA where a dog was extricated from the vehicle.
Yeah.
During the collision.
Yes.
So right off the bat, I called for the dog warden. Dog warden ended up taking this dog to an emergency vet. But the woman on scene who was
For injuries?
for injuries.
Okay.
The woman on scene who showed up to get her husband
Yes.
was hysterical. It's her family, you know, and wanted me to give the dog morphine and everything else. And I was like, I haven't been faced
BLS,
with this yet.
BLS
so,
care by scope of practice.
not even though, right? I mean, so we kept him warm.
Yeah.
We
give oxygen, you can
Well,
chest
I mean,
compressions.
there's some things you can do for canines, especially like, the Belgians, the Shepherds. They can get like bloat where their stomach turns, and we're trained in the military to like put a needle in the stomach to decompress them
the cows,
that could kill them. Yeah, but it's all kind of BLS care as a physician
In the civilian world.
no, even as a physician taking care of military canines, it's fairly BLS care. And so that you would not be, and you're actually not in the scope of practice allowed to give pets, because you're not a veterinarian, drugs. Intranasal Narcan, if somebody were to think that actually happened, I don't know if that would be an issue, but to be frank with you, the reason we use dogs for drug enforcement is because of their long snouts, and they can't get Narcan up to that kind of an effect. That's why humans are not drug dogs, because we'd have to get down there and sniff, and we could actually snort that up our noses. Although I know you're looking at my nose and you're going, "Hey, I think Spanner could be a drug dog."
Our drug dog.
It's amazing the conversations
And all I
these
got to
podcasts
say to
have
you,
struck
I'm
up,
sorry,
though.
Caleb. All I got to say to you, woof.
All right, we're down to our last 5 minutes here. We got 2 other questions. Hopefully, we can knock out real quick.
Oh boy, I know that name.
What about using TXA for nosebleeds? You think it could just?
Oh,
move
I love that.
What do you think it could move from just nosebleeds into more of the role of quick clots?
Oh, it can, although it does not form clots. It stabilizes clots. So you certainly have to have somebody actually have the ability to do that. So it's certainly less effective with anticoagulant medication, but you just hold it longer. And I have used TXA on dressings for sacral decubes that won't stop bleeding. I've had people blow their nose, put it on wadded cotton balls, and squeeze, and it works very well.
What was your case, of skin tear or something like that?
Yeah. A gentleman was run over by his grandchild on a vehicle. And and it worked
A
great.
big avulsion, yeah, that's right.
That's a really good question, and yes, you can absolutely use it in those events. My understanding is it's not horribly expensive. Certainly not as expensive as that quick clot impregnated gauze, which is about $100 a piece. That's why I was always upset when soldiers would cut themselves shaving and rip open their quick clot gauze.
Come on, man.
I'm like, dude, save that for the battle.
All right.
What is this?
Another quick one here. What is the reversal agent for ketamine if needed?
Time. Yeah. Yeah.
Wait it out.
Yep. There's no actual reversal agent for ketamine.
Correct. All right. Well, we need to thank the guys in the back. So hopefully they can put the camera on themselves for a second and then say hi. We got the producer Marco and Dr. Hill back there running the board for the last hour. And thank you guys for getting these questions and whatnot out here in front of us, so we can do our best to answer them. And then we'll everybody that threw a question in there, we'll DM you later. And we got this, like I said, it's got this grab bag of stuff. We'll make Ray send you, since he was the late guy. And
I'll deliver.
No, great questions.
you're going to deliver.
Really good questions. And,
Yeah,
and
fantastic
tell your friends,
questions.
you know,
Saving
Thank you.
lives. Yeah.
tell your friends to come on next time and start listening.
Yeah, we appreciate you tuning in and hearing what we have to say, hijacking your stream for a little bit, and I guess let's see, next month, so next Monday, releases kind of a saving our own story about cardiac arrest. Yeah, cardiac arrest with Dr. Hill, and that'll again run the first 3 Mondays in 3 shorter parts. It wasn't tremendously long, and here we have a special request here.
Oh, hi, Sophia, and Lily.
All right, so here's your grab bag. Since we answered it, we asked their question.
Haley's,
Cassie's like, get it out. We got
Haley's
so much
daughter
stuff.
is Sophie.
Oh, we'll see.
It is Sophia to Sophia. So, all right, thank you so much, and we'll talk to you live in a month. 3 Mondays. thank you all. Have a great day.
Thank you.
Thank you.